Welcome to this Moving to Value Alliance webinar titled Health Systems at a Crossroads. My name is Dr. John Rodis, and I have the honor of serving as the president of MTVA, and will be the moderator for today's session. Just as a reminder, this is a two-part webinar, and part two will be next Friday, November 14th at noon. For any viewers new to Moving to Value Alliance, MTVA is a nonprofit 501c3 corporation whose mission is to cultivate a healthcare ecosystem that prioritizes high-quality outcomes at affordable costs for employers and consumers. We urge our attendees to learn more about us at mtva.org, follow us on LinkedIn, sign up for our emails, and subscribe to our podcast, MTVA Unscripted, which can be found on all major listening platforms. Today's webinar is being recorded and will be available to view on our website. We're joined today by my fellow board members, Dr. Steve Schutzer, one of the founders of MTVA and president of Upswing Health, and Lisa Trumbull, president of Sohn Health, Southern New England Healthcare. Lisa will be curating any questions you submit through the Q&A function on our platform. So please submit your questions through the Q&A function. Our guests today are Dr. Erin Hurlburt, Chris Deacon, and Professor G. Bai. I'll be introducing each of them in full as we bring them in, but let me begin by setting the stage for today's discussion. We know that U.S. healthcare costs exceed $5 trillion, or about 20% of our GDP. Almost 1/3 of that $5 trillion is spent in hospitals. But according to the American Hospital Association, many hospitals in the U.S. lose money, and indeed most operate at razor-thin operating margins, usually between 0 and 3%. Where exactly does this money to hospitals, more than $1.5 trillion, come from? Well, the greatest sources of hospital revenue are governmental payers, specifically Medicare and Medicaid, private insurance, and self-pay patients. Now, one important point to make is that Medicare and Medicaid patients, while accounting for about half of all inpatient days, only generate 1/3 of total hospital revenues. Put another way, private and self-pay patients, while accounting for the other half of all patient days, are responsible for 70% of hospital revenues. In other words, privately insured patients and their employers are paying a disproportionate share of the total hospital costs. Now, there are about 6,000 hospitals in the United States, and they come in many different sizes and types. Some are small, rural, critical access hospitals with fewer than 25 inpatient beds, and some are large urban teaching hospitals with more than 500 beds. I had the privilege of serving as president of one of those. Some of them are specialty hospitals, like children's hospitals or psychiatric hospitals, but most are short-term acute care community hospitals. It's what most of us think of when we say the word hospital. Now, some are for-profit, belonging to systems like HCA, CHS, and Tenet, but most are not-for-profit, which means they're exempt from federal, state, and local taxes because they're deemed by the IRS to be charitable organizations. Prior to 1990, most hospitals were standalone entities, not part of any system. But that began to change in earnest in the 90s with a wave of hospital consolidations took place. Now, this consolidation started predominantly as horizontal integration, in which larger hospitals acquired or merged with smaller hospitals, usually in their secondary or tertiary markets, assuring that referrals for high-end services and procedures would flow into the larger hospitals. This is the so-called hub and spoke model. But then once health systems realized they needed tighter control over the flow of patients, they began acquiring physician groups and practices, especially in primary care. Ultimately, these health systems would acquire outpatient surgical centers, outpatient infusion centers, and imaging facilities to become vertically integrated. This trend has continued so that today about 2/3 of community hospitals are part of a system. Now, most of today's discussion is going to center around these community acute care hospitals and the health systems that they're part of. We could probably all agree that these hospitals play an important role in our overall healthcare system, and in many instances, they're amongst the largest employers in their communities. However, they face tremendous financial challenges, in part due to recent legislation, and in part because everyone is crying out for change of the current system. Our first guest today is Dr. Erin Hurlburt. Dr. Hurlburt is Chief Medical Officer at Lumeris, where she partners with health systems and physician organizations nationwide to accelerate success in value-based care. A family physician by training, Dr. Hurlburt brings clinical and leadership experience to her work driving clinical transformation, operational excellence, and improved patient health outcomes. Before joining Lumeris, Erin served as Chief Medical Officer for Population and Community Health at Bon Secours Mercy Health, overseeing care for more than 800,000 members. In her career, she has navigated mergers, expansions, and policy changes while championing the shift from ill care to well care, aligning incentives and improving financial and clinical outcomes. Erin, thank you so much for joining us today.
Thanks, John. Happy to be here.
So, Erin, if maybe you could expand on what I was alluding to earlier about hospitals, about where they make their money, and in particular, where do they make their profits? Could you articulate some of that?
Sure. Thanks, John. Nothing like a massive and complex question to get us started. I'll attempt to answer this at least a high level. And, to your introductory comments there, I will caveat this by saying I am not defending this. I am a passionate advocate for the care delivery and reimbursement model
Understood.
transformation of value-based care, but just describing it at the current state of where we are in healthcare in 2025. Hospitals are currently generating revenue from two primary sources, operating income and investment income. And right now, the vast majority, usually about 90 to 95% of hospital revenues, those hospitals that you described, is still coming from fee-for-service patient services, meaning hospitals, of course, are incentivized for every procedure, every admission that they provide. The more they do, the more they earn. So those key profit drivers are those high margin procedural based service lines. The big four, primarily oncology, especially through that 340B drug pricing program, orthopedics, cardiovascular, neuroscience, those big four high profit margin procedural service lines. And those emergency departments open 24 hours a day. Those are critical for those admissions. That in those emergency departments, on average, for those community hospitals that you referred to, are driving about 15 to 20% of those admissions. And the gen med admissions that are coming through there and other sources are not, of course, those major profit centers. Outpatient, primary care, and specialty access are critical as well because they are supporting those core big four profitable service lines. Also, investment income, especially for those hospitals with strong cash positions, similar to insurers, they rely on investment income as well to offset the operating losses that hospitals and health systems are experiencing. And investment income is really crucial for long-term viability and sustainability as they're experiencing those very, very razor thin, to your comment, operating margins that those hospitals are experiencing. So Kaufman Hall notes that just from a statistical perspective, the median hospital and health system operating margin is right around 2.5% compared to 3.4% 10 years ago. Now, I think the general perspective of the average American is that, hospitals, make a ton of money, but they have very, very small and sometimes negative operating margins. And that decrease that the hospitals have experienced really has been accelerated by the pandemic and a variety of other factors, including an over-reliance on government payers. So over the last decade, the percentage of health system and hospital revenue coming from government payers, Medicare, Medicaid, CMS, has risen from about 40 to 45%. And this is all occurring in the face of the progress to lower cost sites of care. And these are all just medians, of course, knowing to your opening comments that there's variability in the payer mix, the geography, whether you're for-profit, not-for-profit. But speaking specifically to those community hospitals, this is generally a picture of how hospitals are making their money.
Yeah, it's interesting. You talked about, I know some of the large profitable systems have whole divisions alluded to that are just earmarked for investments and essentially
Sure,
like venture capitalists. It's
that's
very
right.
interesting. Not to mention, of course, stadiums with their names on them,
Yes,
which are kind of big billboards. But
that's
yeah,
right.
no, good point. Now, I thank you so much. It's a great answer, and I'm sorry to hit you with that big first question. The
Sure.
I also opened up talking about how Medicare and Medicaid only account, even though they're half of the patients in beds in hospitals, they only account for about 30% of the revenue, whereas the private patients and self-pay patients account for 70%. So what's all that about? And what is this cost shifting that people talk about?
Right. So to your point, yeah, those government payers, CMS, accounting for half of patient days, but generating a third of those hospital patient revenues. They are paying hospitals, those government payers, at or near the Medicare fee schedule, of course, not covering that full cost of care, especially with that expense inflation that I alluded to in recent years, the pandemic being a big driver of that expense inflation, which requires the private commercial insurers, employers, importantly, then looked as a source to make up that difference, accounting for 70% of hospital revenues, despite representing less than half of those patient days. So hospitals then negotiate higher rates with those private payers to offset the lower payments from those government programs. So a strong payer contracting team is viewed really as a foundational part of the hospital and health system viability. So that has really been, a move that we've seen, is to make sure that those hospitals have a really strong payer contracting team. Supplemental payment programs are also available to help close that gap. Value-based programs that is what we are, all advocates for. Legislative efforts can help to potentially cap those supplemental payments that are based on a percent of Medicare revenue. But hospitals really depend on higher payments from private insurers and employers to subsidize those lower rates. But importantly, another component of that cost shifting is then the downstream impact on all of us here as Americans, the impact on patients, the impact on consumers. The recent Wall Street Journal article that I'm hoping that you all have seen, I'm sure that you have, the average total cost for a family for a health plan in 2025 reaching nearly $27,000, an additional cost shift that all of us are experiencing as well.
Yeah, we've been saying it's unsustainable for, seems like my whole life. So maybe it is sustainable because we're
Absolutely.
doing that. But
Yeah,
no, I think, I'm sure our audience is sophisticated, but the Medicare price is fixed, so the hospitals can't do anything about that. They get what
that's
they
right.
can. And guys like me, we go to school to learn this song of, well, Medicaid only pays 50% of the cost of care that I provide, and Medicare pays about 85 or 87%. So I have to make up the difference somewhere. Hence,
That's
I have
right.
to charge the private folks a lot more. Hence, the cost shifting that I was alluding to. And hey, we were a disproportionate share. We received disproportionate share money at our hospital, to be fair, because we did take care of a lot of poor and uninsured patients. But
Sure.
that doesn't make up the total shortfall, to your point.
It does not.
Hence the private payers, which, and I think to your point, importantly, when we talk about private payers, I think a lot of people think we're talking about Blue Cross or now Elevance or United or Cigna, Aetna, but it's the employees who are paying our copays, deductibles, and
That's
premiums,
correct.
and the employers who are paying
That's
this.
right.
And it's just, I think they're all crying out now and saying enough is enough. We can't do it. Those employers would rather invest that money in their companies,
As they
grow their
should.
business, or pay their employees better, benefits. Indeed, we're taking them, this money is coming out of the hands, and I think Chris has taught me that a long time ago. We're taking the money out of the hands of the middle class in this country. So,
Exactly right.
so we have a system that's predominantly, the health systems and health system executives basically still live in a predominantly fee-for-service world.
They do.
And the more they do, the more they get paid, especially in those high-end services you've alluded to. So how can they possibly pivot towards a value-based economy in which the emphasis would be on things I think you're doing with Lumeris, improving outcome and or lowering the cost?
I believe that we can do this. And that's what we're here. All of us here are attempting to do. And transitioning from a fee for service to value-based model is not an easy one. And the move from a incentive where we're keeping heads in beds, where we're promoting a model of ill care to a model of well care, the work that we're all trying to do, a value-based model where outcomes, cost efficiency is rewarded. It is challenging. We talked in your opening comments about potential for misaligned incentives. As long as fee-for-service revenue exceeds what can be earned in value-based contracts, there's not a great incentive to be able to change. But it can be done. We need to engage patients directly in their own health and wellness. Achieving value-based care requires active patient engagement. You talked about everyone crying out for the need for change. Americans need to understand the importance of their own health and wellness. So the ability to engage patients directly in their own health transformation is important. Scale and capital is really required as well. Entering value-based arrangements, insurance-based models requires a lot of resources, expertise, and importantly, tolerance for risk. This takes time in order for this transition to continue to occur. And many providers and hospitals without that sufficient scale, it will experience, a low or negative operating margin. And, we're seeing this occur, starting to exit these arrangements. And this is where we at Lumeris are seeing hospitals and health systems come to us for that expertise in navigating that clinical transformation, over time, because it doesn't happen with the flip of a switch. So we provide that clinical transformation, assistance and expertise, but we also de-risk that transition because it does take that risk tolerance. So we'll de-risk that transition from a financial perspective because it's a care delivery and reimbursement model transition that has to occur. So when that value-based revenue matches or exceeds that fee for service opportunity, that's when we can start to see that move to value really occur.
And
So
you're able to,
policy changes like
yeah,
those advocated by our fellow panelists, the attendees on today's webinar, that's what we really need to
right.
continue to happen. Accurate data, patient engagement, those are some of the factors that we need to accelerate that transition.
No, thank you, Erin. And you're able to do this. You're able to do this in predominantly a more of a private practice, independent practitioner environment.
That's right.
It's easier, I guess, than in
It
a
is.
as a hospital employee position where your incentive essentially is to see more patients and make sure they come into the mothership for anything to be done. Whereas in the private practice setting you're describing, your incentive is keep them out of the hospital, keep them out of the emergency department, and keep them well and healthy.
Oftentimes that's the case, yes, unless there are some hospital systems and health systems that have made this transition that incentivize their providers in a more value-based incentive model. But the traditional hospital and health system, are really focused on driving volumes to their hospitals. Independent practitioners do have more incentive to move to more value-based care delivery models, and they need those additional revenue streams. So independent practitioners are making that transition to value-based care delivery and reimbursement models in comparison to the traditional health system employed provider. You're exactly right, John.
Great. Well, thank you, Erin. And I know we'll
Sure.
open for questions later. I'm sure audience has questions for you, and you and I have some follow-up. But thank you very much. It's now my pleasure to introduce our next speaker, Chris Deacon. Chris is a nationally recognized expert in the healthcare procurement, policy, and reform. As former director of health benefits for the state of New Jersey, she oversaw billions in public healthcare spending, spearheading efforts to improve transparency, eliminate waste, and hold powerful stakeholders accountable. Chris has testified before state and federal legislatures and is a frequent contributor to national media on issues of healthcare cost, access, and policy. She now advises employers, coalitions, and lawmakers across the country on how to navigate and transform the healthcare system. Chris, thank you so much for joining us today.
Thanks for having me, Dr. Rodis. Great to be here. John.
Well, yeah, and call me John, Chris, for this. In my opening statement, we talked about consolidation in healthcare, and literally when I moved to Connecticut, there were 32 acute care hospitals, and they all were standalone. They all did their own, and now today there's less than a handful, actually, significantly less than a handful that are independent. So, and you have a great book, by the way, that I encourage our audience to read, which I know you didn't tell me to plug your book, but The Great American Healthcare Heist is a great book that everyone should read, and congratulations on that accomplishment. You have a whole
Thank you.
chapter entitled The Crisis of Consolidation. So tell us how consolidation has impacted the industry regarding cost, quality, innovation, and access to care.
Yeah. So, I think if take a step back and we look at sort of the hospital problem, if you will, I don't think we have a hospital spending problem. I think we have like a hospital spending slash boundary problem. If you look in nature, right, every organism grows until it reaches its boundary. Children test boundaries, and plants grow until the soil's
Yeah,
not good, and
correct.
animals follow the fence line, right? Hospitals seem to act no differently, right? Not because they're greedy and not because they're immoral, but because systems respond to the design of the system. So if the design and the boundary says every additional dollar of revenue is rewarded, the system grows to gain revenue, right? And if it says more beds equals more market power, the system will add beds. And if it says higher prices justify the mission, the system will expand, increase prices in the name of the mission. So, here I think we have to take a step, growth and consolidation is not the failure. It's the absence and design of the boundaries of that model that really are the failure. So, I think
Interesting.
that this consolidation, when any organism, like even hospital systems, grow without external restraint, it then dominates, right? And so once the system is controlling the physicians and the outpatient sites and the specialty pharmacies and increasingly the insurance products and health plans themselves, it controls the entire ecosystem. And, at that point, as, I'm sure our fellow panelists, especially Dr. Bai will attest, like at that point, competition becomes theoretical, right? And so again, I think, and you might be surprised at hearing this, and I might be shocking some of our listeners that have heard me rant and rave and get on my soapbox here, but like, we didn't get here because hospitals are bad or they're too powerful. We got here because we sort of outsource that boundary setting role and function to private actors who have no incentive to set the right boundaries. So yeah, so I think that, again,
Interesting.
what higher prices for everyone, less choice, physicians, that are purchased have, suffered moral injury because they are acting in a manner that is not aligned possibly with why they became physicians and what they think is best for their patients. And I think we know, like we can rattle off the statistics about the unsustainable costs that we're all bearing as a result of this consolidation, in part. But to your point, it's not unsustainable. It's will always be sustainable, but at what cost? And
Right.
right now we are bearing a tremendous cost for sustaining this
Right.
model with really inefficient boundaries.
Yeah, no, I think the analogy you make is an interesting one. So to your point, all systems other than this is what the difference between malignancy is and normal cells, right? Malignant cells keep growing on top of each other, whereas normal cells will always stop growing at some point. And all trees stop growing, as one of my former board CEOs, who was a big investment guy, said, used to talk about the stock market. So well, listen, we've all seen a lot of consolidation, a lot of our lives over our, the banking industry is a good example, right? My bank has changed 4 times probably in 30 years and through consolidation. But I'd like to say that my service has actually gotten better over that time, and my cost of doing business at the bank are actually, I think gone down over time. In general, consolidation tends to reduce cost and improve service or quality. But we haven't really seen that in the hospital systems. And to your point, I was actually, you reminded me of a meeting I had with a CEO of a large system in the Northeast who will go unmentioned. And at that point, they were about a $3 billion system, which at the time was really big. And he
Right.
said, "Oh, we figured out that we have to be at least $7 billion to be maximally profitable." And I remember thinking, is he kidding? And I can tell you that system today is at least a $7 billion system, so they've done it.
Right.
But they grew because, to your point, the system incentivized them to grow so they could leverage their market strength to extract higher prices. Is that fair?
Right. Yes. Yeah, exactly. The system rewards that mentality and that behavior. So why would we expect them to act differently as a rational actor in the market? I mean, there are certainly some outlier, cases of hospitals that do engage in bad acting, and we wouldn't excuse that. But by and large, it's a rational response to a system
Yeah.
design.
No, thank
But
you.
in to your point about consolidation in other sectors leading to more not more competition but better services and you know up to a point perhaps, but I think you also banking has become something that you can do. I have American bank accounts because everything's on my phone and I can manage everything from afar. And healthcare is, it is local, right? There may be great competition in the market in, the rest of the country, but if in rural Tennessee within 100 miles, I only have access to Ballot Health, like that's like I don't have there's no competition there.
Got it.
So we have to recognize some of those market forces or lack of market forces. But there has been no correlation. Like everybody says, more efficiency, lower cost, more innovate, like all of the positives. But I can only read so many health affairs articles that disprove that consolidation
Yeah,
leads to
right.
lower prices. Yeah.
Hey, look, we've all seen it. So you're absolutely right. So, so when Erin was talking about where hospitals make their money, she talked about, they make money in their high-end services, they make it in the operating room, they make it in their cancer centers, because again, that was particularly with 340B pricing, which we'll talk about later with Professor Vine. But so why do hospitals bother buying ambulatory surgery centers and imaging centers and infusion centers? What's this whole site of care discussion about?
Yeah, so there has just been a massive purchasing spree by hospitals into the ASC space, ambulatory surgery center and fusion centers. Like, so you have your sort of horizontal consolidation, right, where you have a bunch of hospitals that now are all owned by one hospital system. But now you have this vertical integration going on as well, which is buying up every step of that medical supply chain. So not only am I going to own the hospital, but I want to own the ASCs all around the hospital. And I also want to own the primary care physicians because those are my feeder yards. Um, my husband is in commercial scrap metal, and they always say like they have a loss leader yard because that's where they buy all the scrap in, right? But they have to have that yard open because that's what feeds the big shredder, which is where they make their money. And for that $20 million piece of machinery to be profitable, it's got to run, right? So it's kind of very similar to how many big systems talk about primary care and throughput models. And I've even seen, and you might have seen one of my LinkedIn posts, they've actually referred to OB, behavioral health, and primary care as loss leaders to increase throughput, right? Um, so, that's why there's sort of this expansion. I think there's also a little bit of hedging going on because site neutrality is catching on. So hospitals have bought these outpatient departments or built them because they can charge a higher facility fee. Well, if there are site neutral payments implemented, well, if you own them and you still control the price you charge, maybe it's not a facility fee, maybe it's just the price, but
Right,
I'm a must-have entity and you have to have me, so you'll pay it.
right. Yeah, I know. Hospitals, we used to rationalize our higher prices of a hospital to say, listen, I'm not an outpatient surgery center where I turn the lights off at 5 o'clock. I have to be open 24/7. So there's a cost to be borne for that. But then, to your point, so now I buy the ambulatory surgery center and I still charge this
Right.
hospital outpatient department fee, which is over and above, even though I'm turning off the lights there at 5 p.m. So you're
Right.
absolutely right. We have taken, again, advantage a little bit of that
Well,
system.
I once heard, I pushed back on a fee for a particular, there was a facility fee being added to a hospital-owned urgent care center. And, I pushed back and said, well, why are we paying like a $500 rate for everything that comes through this door when I know that it's ear infections and sore
Right.
throats, right? And yeah, well, the overhead, and there might be x-rays and there might be more acuity and we have to pay for all these things. And I actually asked the question and I don't believe I ever got a full answer, but okay, so how many x-ray machines are actually in there? Number one. And number two, how many referrals to the hospital did you get for x-rays from that
Exactly.
place? And that was a high number.
Yeah, exactly. Exactly. So let's get into some of the solutions. I mean, is it the FTC's job here to break up the big banks, so to speak, break up the monopolies, it's why they started more than 100 years ago, right? Is that the solution? Or and by the way, regarding some of these low revenue generating services, truthfully, I've had some services in my hospital that weren't generating revenue that I wanted to shut down, and or they weren't even that good. Quality wasn't that good. I said, listen, I'm right, I can't fix it. Like, kind of the Jack
Right.
Welch approach. If you can't fix it, close it. But in the certificate of need state, you can't really stop doing that. So is
Right.
regulation the solution here?
Yeah, I mean, there's a couple layers to that question. I believe, right, you're a nonprofit institution who has greatly increased their ability to provide very profitable service lines, right? Okay, let's get on board with that. But as a nonprofit entity, would it not make sense that you would take the profit earned from your stent department and then put it to offset your losses in your labor and delivery, right?
Right,
Because that might not be a moneymaker.
right.
You know, yes, I get that it's not making money, but you're making a ton over here. And isn't that the point of sort of the nonprofit, approach? Because we want to take care of our communities and we want to invest in our communities. And so I'm always sort of at a loss why that isn't sort of the retort more. I do think that there's room for more anti-competitive regulatory action. We've been very, very lax in terms of that. But do I think that that is going to solve the problem? No. I think there's a lot more that needs to happen. I mean, breaking up big hospitals is not going to, solve anything, but having a bunch of, smaller hospitals in a broken system. I don't think that that is the sole answer. It has to be accompanied by a more directional shift. And I think that direction needs to be less middlemen and more restoring of the relationship between the patient, the provider, and with possibly if you're an employer or the person actually purchasing on behalf of the employer. But the middlemen in between, there's 27 entities that touch a healthcare transaction between the time of the service time of payment from the purchaser to the provider. 27 touches, and that's just one way. I mean, that is our opportunity in terms
Yeah,
of waste.
there's in the pharmacy space and even in Steve's orthopedic space, the middleman, it's not the guys who make the joints or put them in, it's the distributors in the middle that make a lot of the profit. It is crazy. Well, that's a good segue to Professor Bai, who's professor in accounting. So thank you, Chris. Thank you so much. So last but not least, it's my pleasure to introduce Professor G. Bai. Dr. Bai holds joint appointments at Johns Hopkins University as a professor of accounting at the Carey Business School and a professor of health policy and management at the Bloomberg School of Public Health. Her research focuses on healthcare pricing, nonprofit hospital operations, and the financial dynamics of the U.S. healthcare system. As a leading authority on healthcare accounting, finance, and policy, Dr. Bai has testified before Congress, and she served as a visiting scholar at the Congressional Budget Office from 2022 to 2023, advising on healthcare policy and financial analysis. Her work has been published in top academic journals, including the Journal of the American Medical Association, Health Affairs, and the New England Journal of Medicine. She's a regular contributor to Forbes, and she writes on healthcare policy and economics. Gee, thank you so much for joining us today.
Thank you so much for having me, John. Thank you for all the panelists. Great opportunity for me to learn.
Yeah, and thank you for your contributions to this endeavor. So, G, in my opening statement, I described the kind of the macro environment of the healthcare space, especially in the hospital space, with about 6,000 hospitals, 5,000 of which are so-called nonprofit, and hence they're exempt from taxes, including state, local taxes, property taxes, because they're deemed charitable organizations under Section 501R of the U.S. Internal Revenue Code that you're familiar with. So what do they do to deserve this special status? I think a lot of people probably don't really understand how this all works. And do you believe they fulfill the requirement to be so-called charitable organizations? Kind of to Chris's last point, actually.
Yeah, great question. So in most majority of the U.S. hospitals are nonprofit. So there's a implicit contract between the nonprofit hospitals and the local community or taxpayers, right? So on the one hand, the nonprofit hospitals enjoy all sorts of tax benefit, as John mentioned. On the other hand, taxpayers demand the nonprofit hospitals to give back to the community, right? So that's a contract. So in practice, how does that work? So the nonprofit hospitals must file the annual tax 990 form to IRS. In that form, they list what kind of community benefit activities they did with a dollar amount. So as a way of disclosure, this is to fulfill the ACA requirement, saying if you're a nonprofit, you have to list your community benefit activities and the dollar amount spent on your Form 990. That's it. There's really no federal level minimum requirement. At the state level, some states do have that, but at the federal level, there's no quantitative limit, except that you have to have that form filled, and also you have to have a charity care policy in place. So that's where we are. So it's not surprising that we found in many cases the nonprofit hospitals enjoy a lot of tax benefit, especially in rich area with very expensive property, right, tax value. And then they do not seem to provide a lot of community benefit to taxpayers.
Yeah, you know, I've been reflecting. You guys remind me of my former job as a president of a hospital, and I know that every few years we had to produce the so-called community health benefit form, basically telling all what we did. And I'm pretty sure I wasn't different than every other hospital. We would throw everything in the kitchen sinks. Then we did provide a lot of care to the community. We had free care. We went out at the barbershops to get, you know, testing for prostate cancer. We went into churches and we had mobile vans providing free care. So indeed, I think we do provide a lot of that care. The question is it really enough to warrant the significant tax break, to your point? And, you know, the 990s, because they also have salaries on there, which, you know, of the executives and any board members, if board members are paid, usually they're not, but the hospital executive salaries, the high-end salaries are also on those 990s, as I recall, because again, as a president, I was on there. And, you know,
Yeah,
we could talk about
sorry, John.
compensation. Yeah, no, go
if
ahead.
I may just add real quick, remember the for-profit hospitals also provide a community benefit, right? So what are the biggest component of community benefit? Number one, charity care. So you give care for free or discount to disadvantaged patients.
Right.
And then for-profit also do that. The second largest component is the Medicaid shortfall, meaning that your Medicaid reimbursement is lower than your cost. So
Right.
our studies found at the national level for both charity care and Medicaid shortfall, nonprofit are not doing more than for. So, you know, they got all the tax benefit, but they're not doing more even than the for-profit, but they're, you know, not paying tax. So that's really the paradox here. Thank you, John.
Yeah, that's a great point. It kind of goes a little bit to what Chris was saying. So thank you. That helps understanding it. So let me move to another break, I guess, that hospitals get is this 340B program. Now, the 340B program, again, I'll just, you know, kind of explain for the audience here. It's been around for a long time. I think more than 30 years. And if I remember how it started because outpatient clinics and federally qualified health centers who are treating HIV or tuberculosis and things like that needed to provide drugs to patients in the outpatient, medications to patients in the outpatient setting that were expensive. And basically the federal government said, okay, we're going to help you by letting you buy this drug at a discounted price. And you could give it to these patients at a lower cost to provide care for them. So it was a laudable goal, right? The idea was to give affordable medications for vulnerable populations. But then hospitals started getting into the bandwagon. Hospitals like mine that provided a lot of free care and charitable care and had a disproportionate amount of Medicaid patients. So we also were eligible to buy drugs at 340B pricing, but then we could turn around in our outpatient treatment facilities and charge retail for the paying customers, so to speak. So what's the story with, because 340B has gotten a lot of criticism. First of all, did I describe it properly? And what are your comments on that?
Yes, it's correct. Thank you, John. It's a complicated system program, but very simple, just like the nonprofit hospital and some governmental hospitals buy low, sell high. So they buy the drugs from drug manufacturers at a deep discount, and then they sell at a normal price. So it's a way to force the money transferred from drug manufacturers to the nonprofit or governmental hospitals. The problem with this program is after the ACA expanded, ACA in 2010 expanded the eligibility for 340B program. After that, the program really ballooned. So now the research has not yet shown that the hospitals enjoying 340B are doing this, are providing more like charity or giving the low-income patients lower price for the drugs. There is no such evidence. So there's a mismatch, right? So they got the buy low, sell high opportunity, but are they really doing something in return to deserve this so-called 340B program's original intention?
Yeah, crazy. Yeah, thank you. It's a,
Thank you.
it just goes back to again Chris's point. The system's designed. You get the result the system's designed to do. So let me shift gears if I can. So Professor Bai, you have a PhD in accounting. Healthcare is one of the most convoluted systems on the planet from an accounting point of view, at least in my opinion, right? Because when I went to business school, we learned all of the colleagues were in manufacturing. And in manufacturing, you have inputs, you make a product, and you have an output. You know the so-called COGS, cost of goods sold, and then you attach a profit margin to it, and that's the price you sell the goods for. Is there any such analogy in healthcare? In other words, is there any correlation between the cost of the goods we provide or the services we provide and the price that anybody pays?
I don't think so. The reason is when we are in a competitive market, the price will be competed back to the cost. Then you are seeing all the manufacturers or sellers try to deprice their price through technology advancement. Then eventually the cost goes down, the price will go down as well, right?
In
But
a free
in
market,
healthcare,
right?
Sorry, John.
In a free market, correct?
Yeah, in a free market, correct. If the market is not competitive, let's say luxury cars or clothing, then the cost kind of low, the price high, right? But healthcare is neither of them. In my opinion, actually, it's the opposite. So the government set the revenue for the hospital, let's say, think about 340B program, etc. So the money obtained from hospital used to expand the budget. So think about nonprofit hospital medical centers. There's no shareholder. So their goal is really expand the pie. That's why we found compare nonprofit versus for-profit hospitals, the cost is so much bigger. It's just not very efficient in nonprofit. Why? Because they got the money, they have to spend. So over time, you see they never get enough, right? They're asking for funding, they got the money, and they expand the cost structure, become more expensive, and then they need more money. So it's a very negative, vicious circle.
Yeah, it's and I should take a moment to give a shout out to our friend Stacy Richter, who just produced a podcast that's very timely on solutions, and I think it's the one that just got published, 492. And she had the president of the president of Beaumont Health in Michigan, Dr. Sam Flanders, and the consultant that helped them, and they were able to make a profit in their hospital at about less than, they set a goal to make a profit at 150% of Medicare, which again, I'm sure many of you know this, but in case you don't, the variability in pricing for some things that I'll call commodities like colonoscopy in, let's say, the New York market can range from 150% of Medicare to 800% of Medicare for the same service, just depending where it is. So there is not, and I think, Michael Porter and Elizabeth Teisberg, of course, wrote this now, 15 years ago. We need a free market, to your point, Professor Bai. This is no market. Nobody knows what the price is. There's no correlation between the cost and the price. And I think Chris hit it on the head, right? We have to have more transparency in pricing so that people can shop more effectively. And by people, and I think Erin alluded to this as well, employers can use this tremendous variability in every other business. When there's a tremendous variability in price, that creates an opportunity for shopping, right? And
exactly.
Healthcare seems to be the exception to this rule, partly because it's intentionally, I think, by design, opaque. So nobody.
Yeah, if I may quickly jump in John's point, let's say,
Please.
John, you and I, we start a new hospital tomorrow.
Yeah.
And if we cut the cost, improve quality, the current system really does not allow us to expand quickly because the patient are not the payers. And then they are confined by their insurance design. So if the insurance does not contract with you and I, you and me, we're over, right? So that's why the current system really prevents innovators, entrepreneurs to reduce the price and improve quality.
Yeah, so true, so true. So let me ask you one final question, G. Is that let's talk about insurance for a moment. So why do I need health insurance for my atorvastatin, which costs $20 a month maybe, or my annual visit to my PCP? Why don't I just pay cash for those services for some of the things we pay for? Listen, I have a homeowner's insurance and I have car insurance in case, a tree falls on my house or I have a car accident. But why do I need insurance for these otherwise lower cost things? And admittedly, we have to provide some safety net, like Medicaid, for those who don't have enough income to cover these costs. What are your thoughts on payment reform?
Yeah, if it's a free market, those services John just mentioned would not be covered by insurance. Any insurance plan that covers everything have no market. Nobody will buy because the premium too expensive. So why we end up in the current situation? Because regulations require all sorts of coverage. As a result, of course, everything covered, but then guess what? The premium is very expensive. And then the patients really lose the opportunity to personally benefit from lower price. And then if we really want to help low-income patients, guess what? We should directly fund them instead of using the hidden tax in the form of coverage. So the better coverage is not the same as better health. I think we have a huge amount of waste and missed opportunities in the current system.
Yeah, we can all agree to that. There's a lot of waste in the system. Thank you, G. Well, thank you to all
Thank
three
you,
of you.
John.
So, Lisa, do we have any questions in our and please to our audience, thank you so much once again for participating today. And please submit some questions to any or all of our speakers through the Q&A function. Lisa?
Yes, the first question is, how do I look up the Form 990 for my local hospital?
You can, if you were to just Google
Mhm.
Form 990 and list your hospital, it will pop up. There is a public, what is it? ProPublica, I think.
ProPublica.
ProPublica. There's a couple of ways you can find it, but ProPublica uploads all of the 990s. There's certain schedules that you might have to request, but the information that we talked about today should be publicly available in those 990s.
Yeah,
for sure.
I've actually done that since I'm on a lot of these forums. I've done that
Yeah.
myself, and even I just go Google 990 for whatever hospital
It's
I was working
easier.
for at the time, and it comes right. It pretty much comes right up. It is publicly available now.
And sorry, Lisa,
you-
it's Schedule
Yeah.
H, if I may add. Schedule H
Yeah.
about all the charity care.
Schedule H is the charitable part. The 990 will show the 10 highest, I think, wage earners. It'll show all the board members, any compensation they get, and then Form H on it is the charitable part of it. Thank you. Anything else, Lisa?
Yes, we do. We have, with 175 million Americans having employer-sponsored health insurance,
Mhm.
what can employers do to impact the system's behavior as fiduciaries?
Chris or Erin, you want to
yeah.
try that one?
Sure. I mean, I think you recognize your power in your question to whomever wrote the question. You purchase on behalf of 165 million Americans. It's not that you lack the power, it's that you lack the willpower to use your power.
Well said.
I just speak very candidly. We have not built an HR or procurement system that empowers employers to actually do that. If we had data analysts, accountants like, Dr. Bai and folks that were very skilled in procurement and risk management running our health benefits plans, we wouldn't be, we'd probably have this conversation, but we'd be in a very different place. Employers can absolutely exercise that power by pushing back and demanding more transparency. And I was going to also comment on G's point about, more transparency will allow consumerism in healthcare. As an employer, right? Okay, so let's all acknowledge where we are today, which is a largely third-party payer system, right? Where we aren't consumers necessarily of our healthcare. As an employer, I am purchasing, right? So
Right.
what can transparency do for me? Not just from a consumer perspective, but I can use that transparency data to make sure that what's coming out of my bank account matches what that carrier says the price of that thing is, or matches what the hospital says the price of that thing is. I can also look and see what I'm paying for service X, and then I can look at the transparency files and say, wow, that hospital is grade A in Leapfrog, but it costs less than the one across the street that everybody's going to, right? I can help educate my members to get better care at the more, the higher value hospital. There's a lot of things that employers can do. And this is one of my latest, like, you can't buy a point solution to fix your health plan. Like, there's no silver bullet. It's, there's no sponsorships here. It is hard work. It's being a prudent fiduciary and asking the hard questions and, rolling up your sleeves.
Yeah, well said. I think it's not the power, it's the willpower. Erin, let me ask you,
Yeah.
because I think you live
I
in
have
this
thoughts on
space.
this as well.
You
Yes.
work with employers directly and health systems. Give us some examples of what we're talking about.
Sure. Chris, I would just underscore the comments that you made about the ability for employers to activate through benefit design and to be able to activate the members and the employees for whom they're accountable. I think your points are very well made. And I'll just give a living example here as living in Cincinnati. The large employers here outside of the health systems, and John, you noted in your opening comments that the hospitals and health systems themselves are employers as well. But the non-health systems employers here in Cincinnati have worked together to hold the hospitals and health systems here in Cincinnati accountable for price transparency, for the outcomes that they are delivering. It's been really impressive. They are requiring the health systems to meet with them on a regular basis, demonstrate the access that they are providing, the outcomes that they are providing, the price transparency that they are offering to their employees. It's been very impactful. So, Chris, to your point, there is the employers, if they are willing, have the ability to move things forward. So just one concrete example, I'm sure that this is happening in other cities across the country, but there is the ability for employers to be empowered and empower the employees and the members that they are accountable for.
Yeah, and John, I missed
go ahead.
I missed the most obvious one, and Erin reminded me of it with, we need our hospitals. We need our hospitals to be financially viable. We need them to keep labor and delivery open,
Absolutely.
right? So what can employers do? Go have a conversation with those hospitals. Maybe, just maybe, they are willing to give you a good rate so that they don't have to work through a middleman and wait 90 days for payment or go through crazy delay processes and denials and there's so much opportunity in that relationship and removing the 27 steps in the middle that we're finding no value in. Like, those negotiating on our behalf are not negotiating better prices. We know that. That's a fact. So have that conversation. And it's a win-win, right? Because we need our hospitals, we need our employers to stay and not go broke. What we don't need is 27 layers in the middle.
Right. And there are pockets. Yeah, we've interviewed numerous people in our MTV Unscripted podcast. The good news is there are pockets of this activity across the country, and Cincinnati certainly sounds like one of them. There's a huge opportunity for employers who are sick and tired of paying this double-digit increases every year and not getting anything for their money. Ironically, by the way, healthcare organizations you would think should be actually the first to do this, right? Because they're actually in the business, but I can tell you that we don't want to do it, because think about if a hospital or health system might find out that, ooh, a lot of our employees are coming to our hospital for a joint replacement, but it would be a lot cheaper if they went to the one across town. Well, they're not going to do that, right? Because they'd rather pay themselves. But certainly in some of the other areas, especially in pharmacy benefit side, there's probably a ton of money that could be saved. You would think they should be the first to jump on this bandwagon. Yeah, great points, guys. Great answers. Lisa, any other questions?
We have a few more questions. So this is to Dr. Bai. How can open marketplaces for services such as traditionally high-cost orthopedic cardiology services be used to reduce the burden and help employers with direct pay options and support employer engagement in a local community? So
sorry, what is the service?
Yeah, it is about the impact. Does the option of open markets around services like cardiology and orthopedics help employers with direct pay options? And does it create further
Yeah.
direct pay options? Does it also support local employer engagement in the communities in a more
Yes.
positive?
Got it. Thank you, Lisa. Absolutely. Thank you, Matthew, for the question. I think if you are an employer with very concentrated labor force, like in the city, like a automobile, what's that called? AW, sorry, in Michigan, right? So everybody is pretty
United
close
Auto
by.
Workers, UAW,
Oh, UAW, right, exactly.
huge union, hundreds of
Then
thousands of
it's easier
members.
to
Yeah.
do this because you can just have designated direct care provider. Doesn't matter specialty care or primary care, you can designate them and then steer your workers and workers' families to those providers. The challenge comes when you have a very dispersed labor force. Let's say I'm Citibank. I have a very small labor force in every place. That you might think, okay, I have maybe 200 people in Charlotte. I'm just making it up, but in that local market, your labor force means nothing. So in that kind of situation, you have to be creative, right? Try to contract with smaller providers so your patient volume makes sense to them, or combine power with other employers to form somehow purchase association. But direct contract can absolutely work as long as you can figure out this labor force issue and have a relatively meaningful patient volume.
Yeah, that's so basically, and I think we've had some people on our podcast that actually attest to that. If you have a reasonable large concentration of employees in a relatively small market, and you know there's a significant price difference between, let's say, the 2 or 3 hospitals to choose from, you can incentivize your employees to go to the lower cost, not just lower cost guys, because it should be the cheaper place, but the one that's better, actually better value, right? And say, you know, you can go there and we'll cover your deductible. As an example, very simple incentive. If you want to go to anywhere you want, we're not limiting you, but if you want to go there, we'll cover the deductible. And even for union members, you can do that because you're not taking away a benefit. You're just saying that, hey, we're giving you this option. And for those not familiar with it, you should look at 32BJ New York in the tri-state area and what they've been able to do for their members and really lowering their cost.
Well, and I think from an incentive perspective, it's, I remember having a conversation with somebody at our TPA in the state, and he was so frustrated because like, I can't control the fact that we're talking about steerage and how important it was. And because they had missed some guarantees that I can't, how do you want me to account for the fact that the hospital that they chose to go to was more expensive, right? And I said,
Right.
well, what are our 2 options to solve those problems? You steer people to the more affordable option, the more affordable high value option, because the quality was good, or you work harder to negotiate your price down. That's the whole point of this exercise, right? Is because then the hospitals are forced to compete. If you're not sending your members there because they have low quality scores, what are they incentivized to do? Increase their quality, right? If you're not sending them there because the prices are too high, what are they incentivized to do? Bring
Right.
down the price. That's
Right.
a market.
Right.
The beginning
Yeah.
of it.
All roads come back to the free market. Lisa, I think we're gonna wrap up at this point. And
Right.
for those who've submitted questions that we have not answered, we will do our best to curate them and get them to the appropriate speaker and get a response to you. So thank you to our audience for their active participation through the Q&A function. So this concludes part 1 of our webinar, Health Systems at a Crossroads. I hope you'll all join us next Friday, November 14th at noon for part 2. Our guests next week will be Dr. Mark Gwynn, Jeff Hogan, and Dr. Angelo Sinopoli. And our moderator next week will be Dr. Marion Couch. I want to thank you all for joining our webinar, and I particularly want to thank Erin, Chris, and G for their input today, and Lisa and Steve, thank you for joining us. Thank you all very much, and I wish you all a happy weekend. Bye-bye.